Okay, so let's talk about Crohn's. It won't be as long, but it's important we talk about it. I am sorry this is taking so long. I want you to be able to get out of here. So autologous HSCT is salvage therapy, and we did it as salvage for severe luminal, penetrating, fistulizing, or stricturing Crohn's. In other words, drug trials do luminal disease only. They exclude penetrating, fistulizing, stricturing Crohn's. Those are the ones we took. They all had luminal, but in addition, they either had fistulizing or stricturing Crohn's. Those are the people we took, and they'd failed multiple drugs, okay? And so here you can see a fistula in Crohn's, and of course it's typical Crohn's, cobblestoning. Actually, General Eisenhower had Crohn's. So I put a picture of him here. Do you know who General Eisenhower's doctor was?
Chron.
Yes, Dr. Chron, absolutely right. In history, another great warrior known as the Black Prince had Crohn's and died from it. And, but he was the pride of Britain during the 100 Years' War and devastated France, such that France lost 90% of its territory to Britain until he got Crohn's and couldn't lead and ended up dying from it. You know, I guess you could argue you don't know for sure, but looking at the symptoms and descriptions back then, we didn't have a diagnosis of Crohn's. It looked like it was Crohn's. In any event, kind of as an aside, the savior of France in the 100 Years' War was Joan of Arc. Does anybody want to guess what the Black Prince's wife's name was? It was Joan. So in the Matrix, kind of interesting. But in any event, we took severe Crohn's, stricturing, fistulizing, and you could use autologous or allogeneic, and we did both, and I'll explain that. The source can be peripheral blood, bone marrow, cord blood. Nobody does bone marrow anymore. And then you cryopreserve, and you may CD34 enrich or not, which is a way of getting rid of the immune cells. And then here's the question. Before we do the transplant, is there an ex vivo potency or efficacy assay? And there is not for the regimen we choose, or for the stem cells, because the stem cells are not therapeutic. And that's a problem for all of transplant for autoimmune disease. So it's kind of through a stepwise approach, figuring out what the best regimen is for each disease. Okay? You don't have an ex vivo potency or efficacy assay. If you're dealing with a drug, for the FDA to license it, you have to have that. In this case, it doesn't exist. There's no way of knowing. It's trial and error. So that's one of the problems with the field. A brief history of Crohn's. Now again, I'm just going over my work. So 2003, we reported autologous HSCT for Crohn's. In 2010, we reported a longer follow-up, 5-year outcome, both in blood. And then in 2014, I just didn't get the time. There's not enough time. But we did 6 patients without CD34 selection. These groups were, and they relapsed much earlier. So I know for this disease, unlike for MS, CD34 selection is important. Now I'm going to talk about the European randomized trial, just a little bit so you understand it, and then our allogeneic results using umbilical cord blood published in 2020 and why we did that and what those results show. Now here's our results reported in blood of transplant for Crohn's, 2010. And here is duration of remission, and you can see by 5 years everybody's relapsed. These dashed lines are 95% confidence intervals. This is the actual number. But 50% relapse by 3 years. Relapse meaning they're going to have to go back on drugs, okay? But it all depends how you define relapse. So do you define it as being drug-free with having no symptoms and need treatment? Do you define it as being endoscopic free of disease, or do you define it as histologic free of disease? What we always did a histologic biopsy on our post-transplant evaluations. Nobody became histologic free of disease. They went into clinical remissions, plus minus endoscopic remissions. They did not become histologically free, and everybody relapses with enough time. And that's with CD34 selection. You have to move this graph to the left if you don't select. Well, for me, those results aren't good enough. They're just not good enough. So we stopped doing it. Now the Europeans just jumped to a randomized trial with this data, and out of Britain. I actually said, hey, you know, our results don't justify going to a randomized trial, but they did. Cytoxin ATG and unselected, so relapse will be even more. And they compared it to Cytoxin 4,000 milligrams per meter squared, one dose, which nobody's ever given to Crohn's. That's a mobilization dose that's excessive. I mobilized with 2,000. So that's half a transplant dose. That is half a transplant dose. So they're comparing transplant to half a transplant dose of Cytoxan. Nobody does such a comparison for a randomized trial. You want to compare to standard of care. So their trial failed. Why did it fail? Because they used an unselected graft that relapses earlier. And they used 2 experimental arms. Transplant dose Cytoxan with ATG versus half a transplant dose of Cytoxan. So of course people got better with half a transplant dose of Cytoxan. And the endpoint they chose has never ever been used in any trial. It was a super strict endpoint. The activity index, Crohn's disease activity index less than 150, no immune drugs, no endoscopic or radiologic evidence of disease. Now they didn't talk about histologic, but they chose an endpoint nobody's ever used. No drug company would use that endpoint. They wouldn't get approval. But it failed, they stopped it, and they did report it, but then they reported again in Lancet Gastroenterology, so I can't remember where this was, JAMA, in JAMA, they reported it. They reported again by looking at a different endpoint. So once you design a trial, you have to report the endpoint. You can't change the endpoint. There's a lot of ethical, statistical reasons why you can't do that. So they then republished the data looking at a different endpoint, and what they found is transplant was significant in their trial for steroid-free, becoming steroid-free, CDAI less than 150, being off immune drugs for a period of time, no endoscopic evidence of disease, no radiologic evidence of disease, and endoscopic healing. It was significantly better at that. And so they reported that in Lancet Gastroenterology. If they had made one of those their primary endpoint, the trial would have been a success. So this is the problem with trials. Everybody looks at the first JAMA trial, say it failed. So they brought out, let's look at the other endpoints, and you can see it's a big success. It's still not a cure. So when you look at autologous HSC for Crohn's disease using cyclophosphamide and ATG, you can say either the glass is half full or half empty, depending which perspective you look at. The good news is you can take refractory stricturing and fistulizing disease and it responds. It does. The bad news is by 5 years, the majority of relapse and they're back on some drug. So all these trials use cyclophosphamide and ATG. Most did not CD34 select, and when we did the 6 without selection, we stopped because we had a much higher, earlier relapse rate. I just never had the time to get around to publish that data because it's just too much going on. So the majority when we would treat would enter a drug-free clinical remission, but never histologic biopsy remission with this regimen, even with CD34 selection. And clinical relapses and restarting drug therapy is common even when you CD34 select with this regimen, 50% by 3 years, 80% by 5 years. So for me, that's a failure for such aggressive therapy. So what do? How do you improve results? You can change your regimen, which I showed you how I did in MS, or you can switch to allogeneic donor or do both, and I did both. And we reported it as a pilot study of non-myeloablative allogeneic transplant. Our regimen was Cytoxan, fludarabine, and Campath. Okay, and Tracalomas, or FK506, Prograf is another name for it, as GVHD prophylaxis and GVH, graft versus host prophylaxis, for 6 months. Well, we were going to go a year. But in any event, we had 9 patients, 3 matched siblings, 6 umbilical cord blood, and everybody had luminal disease, but everybody had fistulizing and stricturing disease. Okay? So we're using a different source for the stem cells and a different regimen. This regimen I wanted for good immune suppression, but also to eliminate risk of GVHD. I didn't want to get GVHD afterwards. So on our 9th patient, we had a death from adenovirus. She went home, was looking good. Her younger brother had pink eye, adenovirus, she got it. It affected her liver, GI tract, and she passed. So I stopped it, and then I just stop, and then I just continued to follow the ones we treated. And of the 8 patients that we treated, 5 cord blood, were followed now for 11 to 14 years, and they all went in and stayed in a complete remission. Complete being defined as no symptoms, on no medications, no endoscopic or radiologic evidence of disease, and importantly, no histologic evidence on biopsy. There's none. Now, 11 to 14 years on all of them. So one matched SIB of the three had mild GVHD versus a secondary autoimmune disease. She had dry eyes and dry mouth. So Sjogren's. I don't know if that's GVHD or secondary autoimmune. The hematologist out in New York called it mild GVHD, so I had to call it that, although I have my doubts. The important thing is there was absolutely no donor engraftment in the cord blood, zero. They reconstituted with autologous cells. They had zero donor engraftment, yet it worked. And so if we look at the three matched SIBs at 6 months, CD3 or T cells, CD33 or neutrophils, donor engraftment, it was low, but it was there, and it did fade with time. If we look at the cord blood, we had at 6 months absolutely no T or neutrophil engraftment from the donors. Yet these went into remission sooner and longer. I mean, now they're all the same, but they went into remission sooner. They were just much easier to follow afterwards. And at 6 months, when the results came back, we just stopped the prograph. They were on nothing. So why did allogeneic cord blood transplant work for Crohn's disease when we had no engraftment? Was engraftment of donor cells missed? So in other words, the first time we looked for engraftment was at 6 months. Perhaps there was engraftment at 3 months and it disappeared, and that early engraftment provided a graft versus disease effect. And so it did help. We just didn't follow engraftment soon enough. That's possible. Tissue engraftment. So we looked at the blood for the donor cells. We didn't look in the gut. But on histology of the gut, there's no lymphocytes. So I think we're not going to find anything there. There's no evidence of disease. Histologically, you'll see lymphocytes in Crohn's patients, even if you're not seeing the ulcers or the endoscopic evidence, which is what we would have after autologous transplant. Here we had nothing. So I don't think that's the case. Or is the donor umbilical cord blood immune cell doing something that we're not monitoring? And so cord blood has common lymphoid precursors, and it has innate lymphoid cells. So innate lymphoid cells can be broken into 1, 2, and 3 that have different cytokine profiles. They are in cord blood. They are not in peripheral blood. They are not in our blood. They're in cord blood, and they locate to our gut, and they stay there. We never see them in our peripheral blood again. So that's a difference between a peripheral blood and a cord blood transplant. Are these playing a role? We didn't monitor for them. Perhaps. Or perhaps it's just the regimen with really no autologous immune cells that were reinfused. But it worked. So outcome for HSC of autoimmune disease depends, of course, on regimen, patient selection, and so forth. So why did this work? Was it something in the cord blood that you don't get in an adult peripheral blood or bone marrow transplant, like ILCs? So anyway, the lowest dose we had used in this dose escalation study, because we kept escalating because we were trying to get engraftment. I was thinking engraftment is important. It's irrelevant for this disease. You don't want it and the risks of it. So we kept dose escalating until we had a death and stopped. But the lowest dose, before we ever dose escalated, was just as effective. Cytoxin 200, fludarabine 7.5, and alemtuzumab 1 dose. Tacrolimus for 6 months. This regimen gives longer than 10-year remissions with no evidence of disease in any way you look for it, including tissue biopsy. So it's been established now as, I think, really good efficacy for long-term clinical endoscopic histologic drug-free remission. And I think this regimen is sufficient for a phase 2 or 3 trial. Now we're ready to go.
Do you keep the tacrolimus even if they have rejected?
So a good question. The first time we checked for engraftment was 6 months. They were all 0, so we stopped it.
Okay.
Why give it when we don't have any donor cells? So we stopped.
So you didn't check chimerism before?
No.
Okay.
Yep. So that's why I said you could argue we had early mixed chimerism with a graft versus disease effect, and then it went away because we didn't check it earlier. Yeah. But anyway, this regimen really worked without engraftment. Actually, not having engraftment is a great thing. You don't have to worry about graft versus host disease. So I think in the future you can use this same regimen at its lowest dose with tacrolimus for 6 months and compare an autograft, I would CD34 select, versus an allograft with umbilical cord blood. I think that would answer what's going on here. That's how I would approach it. Because now we have a regimen that really works. We're talking 14 years, 10 to 14 year long-term remissions, no evidence of disease. There's some cautions here I want to put out there, and we don't have a lot of time. All is caveat emptors. Do not treat short gut, ulcerative colitis, nonspecific colitis, backwash colitis, infectious colitis. So everything that's called Crohn's is not Crohn's. What I demand are skipped cobblestone lesions, granuloma, abscesses, fistulae, or strictures. A lot of people are called Crohn's and they don't have any of that. And I just think of them, a lot of them, as nonspecific colitis till, give enough time, a diagnosis presents. So make sure you're dealing with Crohn's with one of these criteria, which is not being done out there. Alemtuzumab in Crohn's disease, it's unique to Crohn's disease, gives anaphylaxis all the time. And so we had this complex regimen of methylprednisolone, Singular, Claritin, chlorpheniramine, dihydramine, and Tylenol to stop it, to stop that anaphylaxis. It's really weird. I've never seen it using that drug in any, you don't see it in MS. You see it in Crohn's. There's something different about this disease and that drug there. But if you use it, you can give the alemtuzumab. Otherwise, you'll always get anaphylaxis and you stop using it. You know, you just stop and you have to treat for it. Caveat emptor, high incidence of bacteremia because the gut has ulcers and the bacteria are getting into the blood and you drop the white count. Much higher than you'll ever see in like MS. You virtually never see bacteremia in MS. You'll see multiple types of bacteremia in these Crohn patients. So we treat already when we start with oral ciprofloxacin and rifaximin, very potent drug for the gut. We start upon hospitalization and continue until discharge. And as soon as a neutropenic intravenous cephalosporin, cephalosporin when the ANC drops and if continued fever expand. But we've got many positive cultures of ugly organisms, you know, gram-negatives and stuff from the gut in these patients is because the barrier is broken from the disease. Caveat emptor, if you're going to do this study, because I had that one death from adenovirus 3 months after transplant, and there's nothing we could do, nothing. If I had saved her autologous lymphocytes, we could have treated her and reversed it. So if you do this, whether you do autologous or allogeneic cord blood and compare the true, because in the cord blood you're not going to get the graft. So your autologous reconstitution, if you get one of these bad viral infections, preserve before you start the patient, preserve their own peripheral blood stem cells and lymphocytes. So I would mobilize just GCSF, no Cytoxin, and collect on day 4 their lymphocytes, peripheral blood cells, and store them. Don't give it to them unless they get one of these bad viruses that we don't have a treatment for. You know, we have treatment for CMV, herpes. We don't have treatment for a lot of these other viruses, and infuse because they'll have innate immunity to it, and that'll bring them around. So I would do that as a backup, just because I never want to see that happen again. Caveat emptor. This is important when you go in 6 months, 1 year, 2 years, or 18 months, start looking endoscopically. Mucosal healing of the crypt architecture takes time. It often takes 6 to 18 months for it to totally heal. The biopsies won't show lymphocytes under the gut endothelium, but the crypt architecture does take time to heal. And the key to this healing is a marked increase in goblet cells and Paneth cells. And it's interesting, goblet cells make mucin to coat the gut to prevent bacteria from getting in. And there's a marked proliferation of goblet cells. And there's a marked proliferation of Paneth cells, and Paneth cells make defensins, natural antibiotics that coat with the mucosal layer from the goblet cells as your first line to stop bacteria from getting through. And there's a marked increase in those. And I think those are a sign of recovery from this disease. So just be patient. Everything will return to normal by 18 months on the histology. So those are the caveats to be aware of. Here's our regimen so you can have it. Fludarabine, 3 days in a row, Cytoxin 4 days. Alemtuzumab says 2, but 1 dose works just as well, of just 30, 1 single dose. And we get these prolonged remissions using umbilical cord blood with ultimately no engraftment by 6 months. How it's exactly working, I don't know for sure, but it does. And that's why I would suggest that comparative trial to answer that question. Importantly, what I don't have time here to talk about is quality of life in PTSD, post-traumatic stress disorder. It used to be called shell shock. People coming back from World War I sitting in these bunkers like it's going on in Ukraine right now. getting bombarded with shells. They come back and, they're brave as can be. On the front line, they come home and they totally fall apart. PTSD. It's a real thing. And it's a postpartum syndrome in a woman after delivering a baby. PTSD is real. These people get really significant PTSD because they often get Crohn's as teenagers. And your physical appearance to other teenagers is so important at that time in your life. And to know that you have diarrhea you can't control, or you're looking at or do have a ostomy bag, it totally destroys them. And it's underappreciated, and it takes time to recover. But they get marked improvements after this. And it's in my book. Read it. So I talk about 5 diseases in there: MS, Scleroderma, Crohn's, CIDP, and neuromyelitis optica, because we have these long-term remissions in all of them. And I wrote it for everybody because this has to come from patients because of the resistance I meet from the experts in the field who can't do this therapy or don't do it. Patients have to drive it from the bottom up. That's why I wrote this book. And I don't mean that in a bad way. All the specialists in those fields, they don't do what I do. They don't see it, and so it's not paid attention to. Okay, systemic sclerosis. I'll make it fast, unless you have a question. Okay.
Short comentário.
Ok. Sem polêmicas. Falar em português um pouco lento. Nós acreditamos muito no transplante de células-tronco para pacientes com doença de Crohn. Temos 2 pacientes com transplante, uma médica que começou aos 33 anos, em 2014. Ela, 10 years. Uma doença de Crohn refratária, com uso de infliximab. Logo após o infliximab, desenvolveu neurite óptica. Foi uma contraindicação, um alerta por conta do uso do anti-TNF. Nós não tínhamos mais terapia, a paciente estava refratária. E ela foi submetida, foi até protocolo de estudo na Mayo Clinic, não conseguiu entrar no vedolizumab. Nós fizemos o transplante de medula óssea e a paciente remitiu profundamente a doença. Não tem mais, a última colonoscopia de 2022 não tinha nenhuma remissão histológica profunda da doença, sem alterações nos exames de imagem, sem nenhum remédio. Ela estava usando azatioprina, corticoide em cursos por atividade da doença e teve a doença completamente remitida. Em compensação, outra paciente também, mulher, 40 anos de idade, teve também uma doença refratária. Nós fizemos fistulizante, estenosante, não queria ser submetida a cirurgias, foi submetida à terapia, livrou-se da cirurgia, ficou muito bem durante 2 anos. No 3º ano, começou a ter crises e nós entramos com o ustekinumab, Cellular, e a paciente evoluiu com a resposta muito boa, até hoje sem necessidade de cirurgia. Ou seja, conseguimos um ganho que foi não submetê-la a uma cirurgia com alto risco para intestino curto. Então, a gente acredita que é uma alternativa interessante para os pacientes com doença refratária a mais de um imunobiológico, que tenham realmente, de fato, uma doença agressiva e extensa e que se beneficiem do transplante. Eu ainda acho que cabe em pacientes mais precocemente, porque nossa resposta aos biológicos é muito 50%, muito pouco ainda. E a maioria desses evolui com perda de resposta ao longo dos anos. Então, eu creio que o transplante pode ter, por sua segurança em muitos casos, como a gente vê nos estudos, ele poderia até ser indicado em casos não tão restritos como a gente tem visto. É mais essa consideração que eu queria fazer. Obrigado pela aula, professor.
So what I got from that is you've transplanted patients and some did good, right? But I don't, you fill me in on the rest.
We have in our hospital, we did 7 from transplants with CD34 selection.
Good, CD34 is good.
ATG and
Cytoxin.
cyclophosphamide. And I think that 3 of them, they are in remission for a long time. but the others, after 3 years, they will.
Yeah. So it's similar, a sim. Yeah.
And we would like to continue this program, but we were asking for our bone marrow transplant society and also for the government to allow us to do transplants in Crohn's disease out of a clinical trial. And they just approved it.
Good.
1 or 2 weeks ago.
Parabens. So in all of this, if there's anything I can do to help you, you want a protocol, you want a regimen, please ask. All I want is this go forward to help people throughout the world.
We know that.
Yeah.